This is Dr. Srinivas Kumar, sir. I am able to see you and hear you well with a slight delay. Thank you, Dr. Manjunath, sir, and Srinivas, sir. We can see you and hear you well. I have Dr. Ramesh Dagupati, Dr. Saurabh Gupta, Dr. Pratap, and Dr. Dinaka with me. Please introduce your case and go ahead, sir.
Yeah, good afternoon, Dr. Srinivas Kumar, and also nice to talk to Ramesh Dabagatti and Pratap, and also Dr. Sushil. So good afternoon to all of you, and today we are having one TAVI case, and we'll just go through the case history of this patient. So next slide. So she's 78-year-old lady, and his previous history is, yes, she had an anteroseptal myocardial infarction in 2004. Then angioplasty stenting was done for LAD in 2004, and recently she presented with acute pulmonary edema, and the echocardiography was showing a mean gradient of 45 and a peak gradient of 50, and with the dobutamine stress echo, the peak velocity was increasing by more than 50%. So our ejection fraction is 47%, and mild mitral regurgitation, mitral annular calcification is minimal, and it is a tri-leaflet aortic valve with mild calcification. Next slide. So this is the parasternal lang axis of the echo. You can show the mitral valve is normal, and there is a left ventricular hypertrophy and mild hypokinesia of the anterior wall because of previous MI, and there is no much LVOT calcification visible on echo. Yeah, this is short axis. You can see here it's a tri-leaflet aortic valve.
Today the gradient is around 64 and 41.
Yeah, in fact, initially we were thinking it could be a low gradient, low flow situation when she presented with pulmonary edema, but now our ejection fraction has improved at 47%, and gradients are also quite high. The peak gradient is 60, and this is the coronary angiogram. The left main is clean, and stent is patent with little bit of narrowing of 30-40%, and LCX is superdominant, and there is no significant disease, and RCA is non-dominant. We'll show those pictures for you. Next. These are our MSCT analysis using software. Only the aortic annulus area is 350, and the annulus is 21.5. The left coronary height is 8 millimeter, that is and the right coronary is about 10 millimeters. And the annular areas is left, right, and non is around 25.6. It's very close to 26. Only a matter of concern in this particular case, the left coronary height. Left coronary height is 8 millimeters. We normally expect it to be around 10 or 10 plus. But one reassurance is the sinuses are good, and it is a tri-leaflet. Had it been a bicuspid, we would have worried, but still we will take some precautions to protect the left main.
Sir, I think we have Dr. Sushil Kodali also watching through Zoom. I think you have excellently shown that LV dysfunction when the gradient should be less, and when LV function improves, again you got the gradients back. That's one learning thing what we have understand here. And then probably the low coronary height, as you're predicting, is borderline 10 mm. If the sinuses are good, we could still get away. But we also have a talk on this, tips and tricks to how to position it well. Any comments, any precautions you take, Saurabh or Ramesh, this?
Yeah, you know, certainly when it starts
Dr.
getting
Ramesh
towards...
and Dr. Sushil?
when it starts getting towards 8 millimeter, I start thinking about it. I mean, I think here, just based on what we've seen, you should be okay. But it's not a bad idea to protect it. It's easy enough to do, and the downside is pretty low, in my opinion.
Yeah,
The other thing you could do is to take a picture during a balloon valvuloplasty and inject it, and then protect it. But,
Yeah.
But I think it's the same amount of time.
Yeah, I mean the chance of coronary
So that's
occlusion is low.
exactly the thing which, yeah.
Yeah, that's what we are, our strategy. Next, go to the next slide. Next. Yeah, Dr. Sushil, we are also planning the same way. During balloon inflation, we'll inject contrast and see whether left coronary is filling well, so that indirectly give a reassurance that there won't be any pinching of the left main.
Yeah, that's a good plan, Dr. Manjunath.
No, I
Ganesh.
think that's a, yeah, agree. Yeah, no, I agree. I agree with Saurav and Ramesh. I think that's a reasonable plan.
And
these, if they sinuses are challenging, and you sometimes you have to be careful if you have a short sinus, you can seal the STJ with these leaflets. But as you mentioned, I think you highlighted, which is very key, the trileaflet valve, this with this anatomy with the bicuspid valve with non-right fusion would be very high risk for left main obstruction. It becomes lower risk with tricuspid. These are all factors that are important, but there's no way to predict. And sometimes, as you said, it's just important to protect for safety reasons.
Yeah, where?
J-shaped one. The amount of calcium is also not much. It's a mildly calcified. That's another thing which we are thinking. And the sinuses are quite roomy.
Yes. Yes, Dr.
I
Srinivas.
think we should be able to get away as you, yeah.
Agreed. Yeah, agreed.
Yeah, agree with you, Dr. Srinivas.
I mean, those are all factors. If you have bulky calcium,
So,
that increases the risk. So these are all important
Okay,
factors.
J-shaped wire. J-shaped wire. J-shaped Teflon wire. Can we go to the first image and show the
Coronary?
coronary is first? Can you see the coronary? We just wanted to just check it again. Go to the next view.
We can see, yeah.
That LED, mid LED was stented with a bare metal stent in 2004. It's very heartening to see that the bare metal stent is patent almost 18 years later.
Heartening
Yeah,
or
the bare metal
disheartening?
stents yeah.
No, it's heartening.
It's- Fluoro?
We have crossed the valve using the
So-
amplats and the straight termo.
No. Look, your pigtail.
Introduce Martin, sir.
We'll put a pigtail, we'll have a LV aorta
Well,
gradient.
what we do routinely is we cross with the amplatzer and then exchange it to pigtail, and then over the pigtail we will take the curved guide wire from Boston Scientific.
Yeah, that's a very good strategy, especially to make sure that it is not getting, the wire is not getting caught in the mitral
Perforations.
apparatus, especially if you don't use TE.
Submitral,
Yeah.
correct.
Yeah.
I think it's the best practice.
We should not get the
Yeah.
wire should not get caught.
Yeah, otherwise LV cavity in aortic stenosis invariably is small.
Yeah.
So definitely if you don't take this precaution, then it can bite the LV.
Can you show the groin here? We have actually used the Python sheet from, this is the, what we are trying to do is to implant a Merrill valve, my valve. So we have used the Python sheet, which it's a 14F sheet, which is an expandable sheet. The same valve, the same sheet can actually take all size valves from 20 to 32 millimeter. So it is an expandable sheet.
We'll take LV pressure
Yeah,
simultaneously.
that's a really good sheet. In fact, I think It definitely doesn't have a groove like the E sheet does, and it just expands and collapses. I think I really like that sheet a lot.
Yeah, it's like the old solo path sheet.
Yeah.
Remember that?
Yeah.
But Merrill have given a very good name, Python.
Yeah, I mean the gradients, we are not expecting huge gradients to be here because of paradoxical, I mean not, sorry, initially low flow, low gradient AS, right?
Yeah.
And also there is a delay you can see between LV and aortic
Right.
tracing. Yeah, that also indirectly
I
suggests
do
that
think
is
these
significant
hemodynamics,
gradient.
Yeah, peak to peak gradient of 30 millimeters.
and I think the hemodynamics are important. Sorry, Ramesh, go ahead.
Yeah, go ahead, Sushil, sorry.
No, I'm just saying, I think the hemodynamics are important in another way as well. You see the LVEDP, and it's low, and so you know you have some time and room. You know, if you did the hemodynamics and the LVEDP was 30, you also know that you have to do short pacing runs. You might need to recover the patient. The hemodynamics really give you a lot of information that can help you increase the safety of the procedure and shouldn't be ignored.
Yeah, sometimes we have seen this low flow, low gradient aortic stenosis. The actual gradient, peak to peak gradient is just 20-25, but there is a significant delay in the, when you compare with respect to timing between the aortic pressure tracing and LV tracing. And that gets immediately corrected after valve implantation.
What size valve are you taking?
Going by the MSCT, Sushil, we are taking a 21.5 millimeter valve. The first, yeah, balloon. This is, yeah, okay. We are taking a mammoth balloon. 18 millimeter mammoth balloon. This is.
Srinivas cannot go it directly. Do you require a balloon dilatation in this case?
We thought we'll do a balloon occlusion test.
Yeah, so just because of low coronary height, they wanted to do it. And he agreed that you don't have to pre-dilate earlier. The question from Dr. Dilip is whether we need to pre-dilate all the valves. I actually, I mean, the selling point for balloon expandable valves, at least in America, is that you don't have to pre-dilate. But I don't fall for this sales pitch, and don't fall for it. Whether it is, you should base the decision whether to pre-dilate or not based on the valve pathology and anatomy, not just because one step is easier. You know.
Yeah.
So
Yeah, I think it's an individualized
ahead with the
decision
balloon
making rather
dilatation.
than dogma that you always should or you never should.
Actually, Ramesh is emphasizing that it should not be a selling point.
Padmaja, pacing, ready? Mohan, come for injection. 1 minute, we'll tell you.
okay, pacing fine. Okay.
Wait.
Once.
Mohan, you have to.
Okay, it's fine.
Okay.
Yes,
Yes. Go.
Yes.
Inject, Mohan.
Mohan, inject. Yeah. Okay, fine.
Okay, that's fine. Come off pace, pacing off.
Pacing.
Yeah, that showed really good flow in
So
the coronary.
definitely during,
Yes.
yeah, I think we are quite safe as far as left coronary impingement is concerned.
Yeah, there's good
So do
flow
you
in
agree
the
or still you feel we need?
Can we go back and play that again?
I'm sorry. What size? Can we play it again? And what size balloon was that?
18
18 millimeter mammoth. It's okay. It's okay.
Yes.
You can see that there is good flow.
Sushil, are you saying that is the balloon small? Is that your question? What was the minimal?
Yeah, it looks like it's still
21.
there's enough room, but you know, and I think they think the intermediate sizing of the MyVal is nice in this scenario, and you know your sinuses I couldn't read the things, but they look like they were 26, 27. And I think with a 21 with minimal calcified leaflets and a 26,
Yes,
27 sinus, you should
Yes.
be okay.
absolutely. That's a very valid point, Sushil. It's a 21.5 valve,
You can
and
remove
with less calcium, I think we should be able to get away.
How much oversizing is with the 21.5 valve, Dr. Srinivas and Dr. Manjunath?
We are going to have about 8 to 10%.
Oversize.
About 8 to 10% oversizing.
See, actually we are,
Yeah.
21.5 is the valve size, then we'll take 2 ml extra, that gives another 3% enhancement for each ml, additional ml
So
taken.
around 6%. The valve is ready, it is crimped and ready.
The pressure is a little on the lower side, no? Oh, it's coming back up. Okay.
It is 101. Actually, the diastolic has fallen a bit, 32 millimeters of mercury.
Could be some amount of regurgitation.
Yeah.
Fine. Okay. Yeah.
The passage of valve was smooth through the Python sheath.
We'll just check the sinus shootama on.
Okay. Can you
Sinus?
inject?
Inject. Injecting? Illa, inject again.
Okay. It is quite coplanar.
Yeah, the second marker from the LV side should be at the annulus.
Yeah, that looks like a good position as well now, right?
Yeah. Okay, shall we have an injection at this position?
Ready? Inject. Maybe little back. Okay.
This is a good position.
Yeah.
This is good. Okay.
more injection?
Injection?
Maybe 2
Enough.
millimeter back. Would you agree, the panel agree with the positioning of this?
Yeah, I like it because I don't want
Or
it to
should
be
we
too
come back
high
by-
because of the low coronary height here, right? So
Yes.
Yeah, slightly lower
Yes.
here would be
I mean,
better.
it's
This is better.
it's already
This is
hitting the
better,
STJ.
actually.
It's already with the
So
Yeah.
we'll go on pacing now.
Check once again.
you agree, Sushil?
Check once.
I think going higher is tough. 'cause
Illa,
it's
I am
already at the
comfortable,
STJ,
sir.
It's a short sinus, so yeah.
Okay. Pacing.
I think this should be fine.
I think we are going ahead with the implantation now.
Pacing on. Pressure, let it drop. Okay, go ahead with the valve implantation.
Yeah.
Valve.
Yeah. Yeah. Yeah, fluorosafe.
Okay, come down.
Fluoro,
Come down.
Fluorosafe.
Pacing off.
Same what is that? Yeah. Run that picture.
Okay,
Some pacemaker on, pacemaker.
it's okay.
Backup pacemaker.
It's okay.
No, just 70, 80 is okay. It's coming up now.
Okay.
This is 21.5.
Okay. Let us give an injection. Contrast ready?
Yeah.
Some more caudal. Some more caudal. Okay, that's good.
We'll take one injection now.
You want to pull the pigtail back? That's good. Yeah.
No, we will do it. We'll do it. But I thought I'll just take in this.
But coronary flow is good.
Yeah, coronary flow is very good. Yeah, very good.
The other advantage, at least Merrill says, is that wider cells, and the design also is helpful for borderline coronary heights.
Or we'll put wire.
No, but most of the times, Pratap, what is the
Sometimes,
causing is the leaflets come there and occlude rather than the valve itself. So that's also we need to be careful, not only the valve alone. Think great demonstration, sir. I think pacemaker, heart rate also is picked up now, no? Initially you were worried about little bradycardia.
Yeah, heart rate is normal now.
Normal.
Yeah, yes, absolutely. But it's normal.
I think word about pacemaker, right? Balloon expandable valves, I think it is absolutely mandatory to have proper pacing so as to avoid misplacements of valves, whereas compared to self-expanding. Even if you pace a little longer, it's okay as long as the patient is tolerating, but it's always, you shouldn't miss capture of pace here. In between that could lead to valve embolizations and things like that. That's how I think they were extra careful to pace it a little longer. I think could you see the gradients? To check the gradients?
I think we'll flush again.
Yeah.
I think we'll flush and see.
I think both gradient pressures are analytic. Now we can push the pigtail inside.
Yeah. It's actually one peripheral and one central aorta.
Yeah.
LV?
We will even ತೆಗೆದುಬಿಡೋಣ.
ಇಲ್ಲ ನಾನು ತೆಗಿಲ್ಲ.
ತೆಗೆದು ಸರ್.
I think people sitting in the audience, about 200 of them, basically have seen both self-expanding balloon expandable Edwards as well as MyVal now to have varied pictures. So how comfortable are you to adapt this technology? Which one you feel could be better? Balloon expandable, self-expandable? Can somebody raise hands for self-expanding valve? Yeah? Balloon expandable valve?
It all depends on what you.
Yeah, interventional cardiologists.
What you are doing frequently.
Interventional cardiologists, we are comfortable with stenting. No, that's how we take it and deploy it. That's how it looks like that. But I think each of them have their own advantages and disadvantages. And the 34 type of huge, big things, you could do it with self-expandable valve. Unlike over-expanding the Edwards, also you can take more few cc and do it. I think, but that's why I keep telling, depending upon the patient, we need to select the valve rather than having a blanket statement that I'll do only this or the other type of valve. I think the excellent cases.
That's Srinivas Kumar. Suppose if the if the annulus is small, like 18, 19, there probably self-expanding is preferred over balloon expandable.
Yeah, narrow annulus and LVOT calcium, where you have the chance of rupture. That's what people say. That self-expandable could have an advantage.
So. Yeah, you can see the tracing now. There is no gradient.
Perfect. Great result, sir. Congratulations for great demonstration. Any final words?
Thank you.
Final thoughts of advice to every youngsters, Dr. Manjunath, sir. You are also now deeply involved. I think you have done quite a number of cases of MyVal cases. And any final words?
Most important. Final word is decision making is more important than incision, and decision making is more important than intervention.
I think that's what is a great message from.
And treatment should not be.
Yes, sir. Go ahead, sir. Sorry. Go ahead, sir.
And treatment should not be more harmful than the disease.
Great words of
the
advice.
man actually who has done the maximum BMV in the country, probably in the world, is giving an valve therapy. Means nobody can take a word above his level of therapy for valve in intervention.
And Dr. Manjunath is always helpful for any of our meetings. Till now, whenever we requested Jayadeva and Manjunath sir, Srinivas, everybody always supported. Thank you, sir, for an excellent demonstration. And I think we are just finished everything on time.